Hello there. Thank you so much for the opportunity to speak today at the 5th Annual Asia Pacific PWS Conference. My name is Dr. Scheimann. I am a member of the Pediatric Faculty in the GI Division at Johns Hopkins School of Medicine, and I also serve as adjunct faculty at Baylor College of Medicine. And my presentation today is entitled Comprehensive Review of Digestive Issues in Prader-Willi Syndrome. I have a few disclosures, and I will also be talking about some off-label use of medications. If you look at what I'm going to cover in this brief discussion, I'll talk about how common are GI symptoms in Prader-Willi syndrome. I'm going to review published clinical data and management approaches both evidence-based and experiential in Prader-Willi syndrome, focusing in on feeding and swallowing and oral health, gastric emptying, gastric dilatation, and constipation and rectal picking. So how common are GI-related symptoms? Early feeding difficulties are very common among infants with Prader-Willi syndrome. It's part of the major criteria for the clinical diagnosis of Prader-Willi syndrome. And if we look at infant feeding problems, they're seen in 93% of patients. These are two publications within the last 30 years. Emphasize the importance. And then if we also look at it, there are some reports of reflux symptoms as well as the inability to vomit, which can be complicating factors for GI symptoms, with early deaths from aspiration, which may be related to reflux. And there's also significant morbidity with GI symptoms from very high pain thresholds and vomiting thresholds, which is well documented and may not be recognized by medical providers, and that may not allow them to realize the significance of the symptoms and the urgency. So how common are symptoms among adults with Prader-Willi syndrome? This is pooled data from Barbara Whitman, Susie Cassidy, and J.V. Butler, where we look at the percent of adults who had complaints. And if we look at this data that I'm showing you, you can see that between 20 to 50% of adults had respiratory and sleep symptoms and diabetes, and GI symptoms, whether it was diarrhea or constipation or digestive symptoms, were reported by between 18 to about 33%. And that's actually relatively similar to how common is diabetes or skin picking. So not that uncommon among adults. In past data, and if we look at more recent data from the Foundation for Prader-Willi Research Registry in 2019, you can see that this is in numbers of patients, not in percentages, that reflux was not that uncommon in very young infants, less common with age, and it occurred pretty much daily. Slow stomach emptying was not very common in infants, was reported by about 40 out of 700 patients with older children. Gallbladder disease was relatively uncommon. About a third of the patients who were over 2 had constipation. This was a daily occurrence, and even it was reported in young children. And then some issues with diarrhea reported, as well as other GI type symptoms. So not that uncommon. And if we look at the relationship between GI symptoms and causes of death, you can see this is from PWS USA and their death survey, that either choking, GI symptoms, or GI perforation accounted for about 15% of the causes of death. But they may have also played a role in some of the accidental causes related to food seeking. And if we look at mortality in adults with PWS from international data with pooled data from Europe, Australia, Japan, and the United States, you can see that aspiration type events accounted for roughly about 10% of the causes of death. And then the pool for unknown and accidental, there may be some GI issues that are part of that. So as I talk for a few minutes about the GI related issues, I'm going to focus in on a few things. GI actually is a fairly large area, starting from the mouth down to the anus, and it also includes the liver and gallbladder and the pancreas. But for the purposes of this, we're going to focus in on the mouth, the esophagus, stomach, and we're going to focus in on the lower colon. So common oral issues in PWS are reflected from oral motor weakness with hypotonia of the muscles around the jaw, and then a high palate, which makes it hard to transfer food. Some dental abnormalities, including small jaw and small teeth, with delayed eruption and weaker enamel, as well as dental crowding and erosions from rumination. And then abnormal saliva, which makes it very hard to transfer liquids and solids, with the flow of saliva in PWS measured at only about 20 to 50% of normals. In prior data and updated by our dental colleagues in 2012. So what can you do about that? So we looked at, since this is a very common thing in infants, we looked at using therapies to see if we could cut down the amount of time you have to use supplemental support. And using occupational physical therapy to help with positioning, and then with strategies to help with transfer and devices, you could decrease the amount of time from 230 days down to about 47 days with using therapies. With using nutrition, you could cut the amount of time of using supplemental feeds from around 90 days down to about 45. And if you used both, you could cut the amount of time down to about 42 days on average. So again, using strategies of either concentrating fortified breast milk, or adding concentration to formula, and then using proper positioning and devices can cut the amount of time you have to use supplemental support. So definitely a tool to use. And then if we look at swallowing issues among adults and children, unfortunately, this issue that's there in infants doesn't appear to completely go away. In a study that was published in 2014 by PWS USA through a group of investigators out of Pittsburgh, they did swallow studies in 30 adults with PWS using thin liquids and barium cookies to get an idea of transfer for both liquids and solids, and they found that there was a significant substantial pharyngeal residue present in 29 out of the 30 subjects. Again, no GI history was available for them. Some of them could have had surgery that might have caused some of that. And then they did see that there was slow passage through the esophagus in 100% of the patients. And the key there is that none of those adults could feel that there was anything sitting in the pharynx, or that there was slow movement through the esophagus, regardless of the amount. So again, stuff is sitting there at risk to have either go into the lungs or sit there or potentially cause obstruction of the esophagus. So if we look at data as we extrapolate from that, knowing that it's common, well, what do we know about that and the role in potentially deaths? 40% of families who reported a history of choking among those who completed questionnaires, and choking was listed as the cause of death in about 8% of the patients. The average age of those that had choking as the cause of death was 24, and nearly all of them were males. The factors that predisposed to choking were food seeking in at least a quarter of those who had a choking episode, the thick saliva that we talked about before, having weak muscles in the pharynx so it would be hard to clear it, and then also having gastritis or reflux. This was noted in about 40% of those who had an autopsy, which might affect how things clear through the esophagus. So what can you do for that? Making sure that people both at the house and in group home settings and in the school setting are trained to do the Heimlich maneuver, and then using strategies with diet, supervising meals, making sure at holidays that PWS patients are monitored closely for quick sneaking of food and the potential for choking episodes, making sure they use the strategy of pacing and chasing when they're drinking and eating to help clear things through the esophagus, using self-regulation of fluids with a straw, and then also treating for gastritis or reflux if present to help with the esophagus function. So I'm put this in here to allow me to make a transition. So I'm going to be transitioning over from looking at the top down to the stooling, and this is the Bristol stool chart. I'm going to assume that most people know about that. If you could raise your hand if you're familiar with this. And what we're looking at for defining constipation would be a Bristol stool chart class of type 1, type 2, or type 3. The longer that stool sits in the colon, the more fluid that's pulled out and the more it takes on the shape of the colon. So we will be focusing in on this. I mentioned to you before from the APPWS data that constipation is not that uncommon in children, both in infants and young children and older children, but this is actually among adults. And these were published data from our European colleagues where they looked at the frequency of constipation and Prader-Willi syndrome. 21 patients with PWS were seen at the AHAR Center, where they looked at constipation history, the rectal exam, and the rectal diameter by ultrasound, as well as transit time through the colon. And they compared that to 30 volunteers who were close in age, a little bit younger, and had a similar BMI who served as controls. Symptoms reported were infrequent stools, less than 3 per week, and 47% of the PWS patients, with straining in about 40%, and hard stools in a third of the patients. There was no difference between the PWS and controls in the size of the rectum, suggesting there wasn't a problem with airway function, or in the transit time through the colon. And in a separate study, which just was questionnaire-based, about a third of the patients with PWS who were adults reported symptoms of constipation. So if we look at what could predispose to this in Prader-Willi syndrome, this gives you an idea of the pelvic floor anatomy. And here we can see that at rest, there is something called the sling of the pelvis that will pull away the rectum to give a little bit of space to help hold poop in place. And that when you're seated appropriately, this lines up to make it easier to defecate. allowing for descent of the floor to make it easier to stool. So instead of having more of an S shape, it's more of a straight line passage. And what this translates to in using the toilet is that you don't want your feet to dangle because that keeps that S-shaped passage there to make it harder to go. You want to actually instead make sure that you have your feet straight, which will allow things to line up appropriately. If we look at interventions for constipation, there's some nutrition interventions that can be used both with increasing fluid, using flaxseed or essential fats, because those can help with lubrication. We typically don't use mineral oil because of the risk of aspiration. Magnesium compounds can help the bowel to contract, and these are okay to use provided there's normal renal function. And then there also are polyethylene glycol compounds such as Miralax that can be used that pull fluid in to make it easier to go to the bathroom. We often don't use some of the compounds which would be X-lax based or stimulants because in the US they're made with chocolate, or which may be a little bit tempting for PWS patients. And we often don't use lactulose as often because it's a sweet liquid. But these would be some strategies that could be used for constipation. Just to make sure I cover very briefly, rectal ulcers can happen in PWS. Fortunately, not very common. The strategies for this to help treat it would be to relieve constipation, which causes to happen, and then to avoid straining during defecation, which may trigger more behaviors to help to pull the stool down. Using stool softeners to keep the stool soft, and then to use strategies to cut down on the amount of itching from bile acids by using something called cholestyramine may help with cutting down on the triggers for this and to help heal. And then using behavior modification to decrease digging behavior by having timed amounts of time in the bathroom, and then reversing clothing to decrease anal access at bedtime by using like a onesie, pajamas that are oversized and with a zipper placed in the back to cut down on the access to the rectum. And then also using biofeedback and physical therapy to help address toileting postures to help cut down on the desire to assist with defecation. Jim Locher and I did put out a constipation alert for management of constipation in individuals with Prader-Willi syndrome. This can be found through PWS USA. And the key thing there is to realize that failure to clear stool in a timely manner in the setting of pain, distension, or decreased appetite warrants a surgical or GI consultation, and not to take this lightly. I'm going to end the presentation today by talking about gastric dilatation. Here we can see an X-ray where there is a very large stomach in this picture. It should only take up 1 quart, but it takes up more than half of the abdominal area. If we look at this, this was first described not in PWS in 1883 with severe gastric dilatation described by Simon Emmanuel Duplay. And it's been reported in the past in dogs related to a stretch and then twisting of the stomach along an axis, which can allow the stomach to be able to decompress. In 1859, Brinton suggested there was an atony or inhibition of the gastric nerves that allowed the stomach to become very distended. And some thought is that there may be a feedback problem with messaging coming down from the brain. It's a location called the solitary nucleus that's been found to potentially be abnormal in PWS. We look at the role of the stomach. The lower part of the stomach is where churning and grinding of solids occurs. The upper part is where the reservoir is, and this is the part that tends to become very dilated in PWS. Gastric dilatation and necrosis, as I mentioned before, in dogs occurs due to a stretching and then a twisting of the stomach along the axis, which doesn't allow the stomach to be decompressed. It's been reported in humans and anorexia and bulimia patients, with undernourished patients complaining of abdominal pain after meals, and then allowing for things to become distended if there's a binge. And then the problem is that wall of the stomach that looked thick in that initial picture becomes very thin-walled. It becomes distended, allowing bacteria to track in and then cause gas production and injury to the wall. And as the wall becomes thinner, it becomes more of a compromise of the vasculature of the stomach, which could allow for perforation. And again, I mentioned to you in the prior data that there may be some suggestions from animal models there may be a problem with crosstalk with the solitary nucleus. In PWS, this was first reported by Bob Wharton in 1997 in 6 women with vomiting and gastroenteritis who developed rapidly progressive swelling of the stomach followed by necrosis. 2 of the pediatric patients fortunately had spontaneous resolution. 1 patient died of an infection, and then 3 patients unfortunately had massive dilatation requiring resection of the stomach in 2 out of the 3 patients. There was also reported around the same time frame in a patient with PWS who died about 45 days after having gastric banding for morbid obesity. Unfortunately, that patient was not supervised and was allowed to eat ad lib. So the thought is that perhaps this band caused constriction and didn't allow the stomach to be able to appropriately dilate up and for the patient to be able to vomit. If we look at more recent data published within the last 15 years, there were 4 patients out of 152 that died from gastric eruption and necrosis, with another 3 suspected. So that would raise about 5% of the patients that may be related to this cause. The descriptions of those give us a little bit of keys. There was a teen who was not obese who had binge eating on a holiday followed by belly pain and vomiting. There were 2 young adults, again, not obese, who had belly pain and vomiting, and then some middle-aged obese adults who had a history of an ulcer and gastritis, and then another child who had belly pain and threw up some blood. So with this, it's difficult to diagnose. You should have a high index of suspicion. Clinical features include a change in diet before development of belly pain and vomiting. And the x-ray, just like I showed you in the first one, shows a very large dilated stomach. The key is that we have to get that stomach down, either through using clear liquids if the patient is not that sick, or using measures like placing a tube through the nose to help decompress the stomach, and then use supportive care, as well as monitoring closely for development of possible rupture. There's an algorithm that Jim Loker and I developed. It's through PWS USA. Please feel free to use this. You can get it off the website, or you can let us know if you have any questions. There are some treatments that can be used if things resolve and gastric emptying continues to be slow, with use of erythromycin or metoclopramide or domperidone. And the other key thing is to remember that constipation is lower down. If things are slow from below, it's going to definitely cause things to be slow from above. So again, I've talked for just a few minutes to cover a little bit of GI issues for how common they are and focused in on a few areas. I'd like to acknowledge the collaborators who've worked with me over the years, some mentors, and then the Texas PWSA clinic staff, the PWSA USA and FPWR, both for research funding and for support, as well as IPWSO, and most importantly, the families of children with PWS. And again, this is a picture of the camp in Texas for PWS. It's been going on for more than 15 years. And I love taking care of PWS patients, and I'll be happy to answer any questions that you may have. Again, thank you so much for the opportunity to speak today.